Thank you, everyone. Thanks for that kind introduction, and thanks for having me. Trying to see if I can advance this. And so I'll get quickly to where I want to talk about, because I have a lot of ground to cover. One of the main things that we always talk about, vascular involvement, lung involvement, but one of the big problems in the scleroderma, as we all know, is the GI tract involvement. And when we say GI tract, it's not a small thing. Just the lumen is about 25 to 30 feet, considering that there is esophagus, there is stomach, and then small bowel, which is 20 feet, and then the colon, which is another 4 feet. And then on top of it, we have the liver, we have the pancreas, we have the salivary glands and all that, and literally everything can get involved in scleroderma. But today I'm going to mostly talk about the upper GI involvement, which is the top of the small bowel, the stomach, and the esophagus. And we're going to go through a little bit what GI tract does. Remember, digestion is just one of the things that GI tract does. For example, the absorption and getting the whole sort of food broken down and getting it in your system is one thing. But it also harbors gut microbiome that now we know it does a lot of good things. Sometimes it becomes a bad player and it does a lot of bad things, right? So you have to keep that balance for it to behave normally for us to, for our body to function. And also the liver does detoxification detoxification of the toxins that we eat, and also clearing a lot of bad things when we eat out of our system. So if the liver is not functioning, that would be a big problem for us. Also, we talked about a lot of immune therapies, but remember that GI tract is a big part of our immune system, and in fact is the biggest collection of immune cells outside of the bone marrow and lymph nodes, right? So that makes it a big player in all autoimmune disorders, including scleroderma. So I'm going to be a little bit more practical for the rest of the talk, meaning that, okay, what tests are there available? How can things be checked in the setting of upper GI involvement in scleroderma, right? So if we think about the esophageal test and involvement of the upper part of the esophagus, which is where the swallowing occurs, and then the rest of the esophagus, how esophagus moves down up until it attaches to the stomach, there are multiple tests that we can do. I'm going to show you some pictures. Obviously, I can't cover all of this, but those are the tests that we have. For example, we have manometry to see how the esophagus is contracting. We have endoflip, which is a new device that during endoscopy, we see how distensible the esophagus is and how distensible the sphincters are. And also we have the good old esophagram, and which is essentially you drink a barium and different consistencies of the barium to see how things go through your esophagus, how you can swallow, and where the abnormality is. When it comes to stomach, there's other tests as well. So we have gastric emptying tests, which is when you have the standardized meal that you eat, and then we monitor via nuclear imaging how much that stomach is emptying within a 4-hour period. That is called gastric emptying test, which is very common, and it's done in a lot of places. But now there is gastric emptying breath testing, so which is easier. It doesn't have any radiation, and essentially you have that standardized meal, which is more palatable, but you just blow into these tubes for about 4 hours, and then we see whether the contents of the stomach is passing through. Because a lot of times stomach is slow in scleroderma. That obviously affects the symptoms of reflux, it affects the symptoms of fullness, distension, and also affects how you get your nutrients to your body, right? So that's a very important factor in scleroderma. We also have gastric body surface mapping. That's a mouthful of words, but simply it's an EKG for your stomach. The same way that your heart beats and it has electrical activity, your stomach has the same sort of pattern, but it's just like exponentially more complex than heart because it does not have that usual wiring of the heart to contract. So now we have these devices that I have some pictures for it, that it tells us what's going on with the stomach. Because the same way that your heart can have arrhythmia, so it's beating abnormally, your stomach can beat abnormally. And that's actually common in the setting of autoimmune disorders. Just to show you how these tests look like, this is an esophageal manometry catheter. So it's 36 centimeters, and it goes through the nose, and that's me getting it. And if you want to watch a YouTube of me getting it, so you can go in there. And that's Vicky, our nurse, doing this. You know, we do a lot of clinical trials, and then whenever whenever we do clinical trials, we need healthy controls, right? So for esophageal manometry, nobody volunteers for it, so they just grab Dr. Rezaie, as always, to be the control over there. But that's how it's done. So it goes through the nose, it sits in the esophagus, and then you take small sips of water, and we wash how esophagus contracts. And this is how esophagus contracts. As you can see, this is the, so on the right side is the anatomical index. You can see that this is the sphincter up here. This is the whole esophagus. And this is the sphincter that connects the esophagus to your stomach. And this is the stomach, right? So the colors are pressure, right? So that's the pressure of the sphincter up there. And this is when you swallow. Obviously, when you swallow, the pressure drops. It becomes a little bit more blue. And then the esophagus kind of makes this contraction like a snake and pushes things forward all throughout the esophagus and dumps everything into your stomach, right? And the purple is actually the flow of the liquid. And you can see that the liquid very nicely is pushed into the stomach, and there is nothing left in the esophagus, right? This is a normal contraction. But this is one case with scleroderma when the esophagus is involved, right? The smooth muscle is not contracting anymore, right? And that contraction that we saw here, specifically this part, which is the smooth muscle, does not occur, right? So you don't see it anymore. And this sphincter at the bottom that we saw the pressure here, right? This baseline pressure, the sphincter has lost its tone, has lost its pressure, so you don't see that. So what happens is that now when you eat, obviously, food going down and getting into the stomach is dependent on gravity now. It's because there's no contraction. You just have to wait until it goes down by itself, right? And also, when there's acid in the stomach, because there's no pressure in the sphincter, stuff comes back up, right? So acid reflux occurs, right? So that's why we use a lot of antacids when this happens. When we use a lot of prokinetic drugs, meaning that drugs that help stomach push forward in this scenario to help patients, because we have lost the snake movements of the esophagus. So we do test for amount of acid that comes to the esophagus as well, and that can be with a catheter, similar to what you saw, or it can be endoscopically. With an endoscope, we go into the esophagus, we place a tiny capsule in the esophagus, it's called Bravo capsule, and it measures acid over a 96-hour period. And then after 96 hours, usually it just falls off, you just poop it out, you just don't know where it went. But that kind of gives us the data, how much acid is in the esophagus. So this is a relatively new test, so I thought maybe I'd talk to you a little bit more. This is gastric emptying breath test. Probably you're familiar with gastric emptying scintigraphy that we do in radiology. This is now something that we do in the offices, that we give you this meal. This is actually a very cool concept if you think about it. It's C13 spirulina. So what is spirulina? It's actually a type of seaweed. So the FDA grows seaweed with C13 in very specialized labs, right? So this meal, which is mixed with egg, you have this, and this gets digested, right? As it gets digested, it gets into the small bowel, and when it gets to the small bowel, some of that C13, because usually the carbon that we consume is C12, but C13, when it gets in your system, you breathe it out, right? And you breathe it out, and we see that ratio of C13 in your breath, so we know how much of that meal you digested and consumed. So that's the way we see whether this food is getting absorbed or not. So it gives us a curve that this is normal, because as you ingest the meal, the C13 starts to rise in your breath. And this is a normal person. The blue is a normal gastric emptying breath test. But this is somebody who's abnormal. It's not going up. It's just food is just sitting in the stomach. So as compared to the old version of doing this, the pros are that this is non-invasive, no radiation exposure, and also this is safe in children and also pregnant and breastfeeding women. So this is something that a lot of times we're switching to this because it's easier, and also because there is no radiation, we can repeat it multiple times to see if our treatments are working or not, right? So that's one improvement that we have had in our testing. Another test that we have been involved heavily with is this. Remember, I said this is similar to the electrocardiogram for heart, but this is just for your stomach. So it just sits on your stomach. It has 64 sensors in a big array. And we'll see whether it detects the contractions and electrical activity of the stomach. Same concept. You eat a standardized meal, which is modifiable, but we usually use a Clif Bar plus Ensure. The reason why is that we need a good mix of carbohydrates, protein, and fat in our standardized meal. It's not that I'm encouraging this is a healthy meal to eat, but it just has to be standardized between the patients. So that's why we're just doing this. And then we follow the patient again for 4 hours. And by the way, you see that all these motility tests, they're not like a 2-minute thing. So it has to be hours to days, right? Because GI tract has very long cycles. So to get a good sample of how your GI tract works, you need hours and days of data to get a sense of, okay, what's normal and whether you fall into the abnormal part or not. And, the contractions of the, I just put this up there not to go exactly into details, but just to show you how complex contractions of the stomach is. And small bowel is the same. Just like heart, there are pacemakers in between the smooth muscles in our whole gut, and they continuously produce waves depending on what stage of eating you are. The way they behave after you eat and while you're fasting is completely different. So that's why it's very complex to figure out what's going on with just one snapshot of the time with these patients. And this is what it spits out, essentially. It gives us a result that shows us how often the stomach is contracting. This is number of times that stomach is contracting per minute from 1 to 6. You can see that the normal is 3 per minute. So at this time that you're sitting there, if you have a normal functioning stomach, every 20 seconds it's contracting. It's contracting. So that's actually become abnormal in a lot of disorders such as diabetes. It can get abnormal in scleroderma, and depending on what abnormality shows up, we treat it differently. The next thing that I wanted to talk about, which is very hot topic, is obviously gut microbiome. So what is gut microbiome? Is the collection of all bacteria, fungi, and archaea and viruses, right? I mean, if you want to go back to the three domains of life. Remember, all like microorganisms, all living things on our planet fall into three categories, right? Archaea, which were the original forms of life, bacteria, and then eukaryota. These are fungi, these are insects, these are us, all the ones with big cells, right? And then there are viruses that actually, they're not alive, so that's why they don't fall under the three domains of life. But interesting enough, we are all four of them together. So we are the combination of archaea, bacteria, and human cells, and viruses, right? So all together. So this combination of things is very important. Obviously, modern medicine has mainly been focused on this part of things, but now we're understanding that these are important as well, not just the invasive ones, but also the native ones that are just sitting there. So for example, and now we know there are a lot of viruses called bacteriophages that are sitting in our gut, and those guys essentially eat bacteria, right? So how much they eat bacteria is very important for those native viruses that are living in us, because if they die or they're gone, then those bacteria they used to eat, now they overgrow and they do bad things, right? So all that is a very active field of research. And this is very common in the scleroderma, the microbial overgrowth. In fact, scleroderma patients have pretty much the highest rate of small intestinal bacterial overgrowth as compared to any other patient population. It's about 44% of scleroderma patients have bacterial overgrowth. And that is actually tenfold more than the general population that we see. And that, what is that exactly? So if you think about it, in your mouth right now, you have about 1 billion bacteria per every ml, per every cc of your saliva. It's just sitting there. It's 1 million bacteria right now. You just swallowed a couple of cc's. You just swallowed a couple of million bacteria right now, right? But in your colon, it's actually more. In your large bowel, is about 1 trillion, right? In each cc of poop, there is like 1 trillion bacteria sitting there. But interesting enough, when you come down to your stomach, is less than 100, right? It's the stomach acid and the enzymes just kill it. And then in the small bowel is less than 1,000. So as compared to large bowel, small bowel has 1 million times less bacteria in it. So how does it do it? It doesn't have antibiotics. So it does it by continuous moving, all the movement that I talked about, but continuously pushing the bacteria back to the colon, cleaning itself. What we call, in fact, actually, we call it housekeeping waves. Housekeeping waves are waves that start every 2 hours. They last only 8 minutes. They clean the whole small bowel and dump everything into the colon by a sweeping movement, just like sweeping. They just mop things forward and dump everything into the colon. And those are called housekeeping waves. Interesting enough, housekeeping waves are affected significantly in patients with autoimmune disease, especially scleroderma patients. And that's why patients with scleroderma have a very high risk of getting small intestinal bacterial overgrowth, getting other overgrowth syndromes such as intestinal methanogen overgrowth, and also small intestinal fungal overgrowth. So what's the consequence? The problem is that now these bacteria and fungi and archaea that are overgrown, that are sitting in the gut, they need to be fed, right? So when you eat, some of the food that you eat, you digest it, but some of the food that you're supposed to digest, these bacteria, fungi, and archaea beat you to it, and they start digesting them, right? What do bacteria do when they get extra food? They start fermenting it, right? So they produce gas, they produce hydrogen, they produce methane, hydrogen sulfide, carbon dioxide. So the small bowel becomes like a little bit puffy, right? Full of air, right? And also they produce a lot of side products, and these side products can have different effects on the gut. It can cause diarrhea, it can cause constipation, it can cause even brain fog. Now we know the other effects that they are having. So it's multitude of effects that they have, right? But the classic symptoms are postprandial bloating and postprandial abdominal distension. Essentially, after you eat, you feel like you're getting more and more bloated. And if you fast, you feel better. That's the classic symptom that we see in the setting of overgrowth syndromes. How do we diagnose them? Interesting enough, FDA just last year assigned ICD codes to microbial overgrowth syndrome. And diagnosis is by breath testing, that you can diagnose intestinal methanogen overgrowth and bacterial overgrowth. And also by small bowel aspiration. So essentially that's an endoscopy that we perform. We send the catheter into the small bowel. We suck that juice in the small bowel, send it to the lab to see what grows, okay? But in that scenario, we can't grow methanogens because the commercial labs can't grow methanogens. They're really hard to grow. They need high pressure carbon dioxide and methane and also hydrogen. I mean, we grow it in our lab, but it's a very tough thing to do, and it's just for research purposes. So these two are the complementary tests that we do to diagnose these microbial overgrowth. The tests with looking at the DNA signature of these microorganisms are coming, but it's not really a prime for clinical practice yet. And the stool tests that you probably have seen commercially, they do not diagnose any of these. So they're not primed to do any of these because stool is representative of the colon and not the small bowel, all right? So keep that in mind. All right, how do we diagnose, and this we just talked about it, but how do we treat this? Obviously, we try to help with the motility of the gut if there is something at baseline that we can fix, but most of the times there isn't. So we go for induction of remission. I'm gonna go a little bit into detail. With antibiotics, essentially, we decrease the amount of these microorganisms in the gut. Or we can do it with a elemental diet if antibiotics are unhelpful, or we do maintenance of remission, which we use diet. And MMC phase 3 is actually those housekeeping waves that I was talking about, that we give medication to push the small bowel further. Just to give you an idea how effective they are, they're not bad, but they're not miracles either. So antibiotics are roughly effective in 50% of the time, i.e. 50% of the times they're not effective, right? We still have to do much better in doing this. And the usual antibiotics that we use is rifaximin, ciprofloxacin, neomycin, Bactrim, metronidazole. And you know, they all have their own side effect profile that for each sort of a patient, we decide which antibiotic to go. And in reality is that it's also dependent on what insurance covers what as well, right? So that's one reality of which treatment we use, right? When it comes to archaea, which produce methane, those are even tougher to treat. If you use single antibiotics, they only are effective in about 1/3 of the time. So you have to do combination therapy, and with combination therapy, you're more successful in treating them. But again, this is even tougher to treat as compared to bacteria because the cell walls are very resilient to our usual antibiotics that we use. If we fail all this, we use elemental diet, and this, to give you a little bit of a brief how this works. Essentially, elemental diet, everything that you eat is carbohydrate, fat, or a protein, right? So those are the main 3 ingredients that get absorbed. But for them to get absorbed, they need to be broken down. Carbohydrates break down into monosaccharides, protein break down into amino acids, and fat breaks down into fatty acids and triglycerides, right? So elemental diet is all those ingredients broken down to their elements. So it's already readily to be digested, right? So you don't need digestion. Everything gets absorbed, right? And this is not a new concept. This was a concept that was introduced roughly in early 70s for two reasons. Number one, for burn victims, because they could not catch up with their absorption, and TPN hadn't improved that much at that point. Number two, for NASA, because they wanted to have like a diet that has no residue, so you don't have a bowel movement, so we can send people to space. So that's actually how it started. But then, obviously, the big application at that time was that for kids who had milk allergies and a significant amount of allergies, because these diets have no allergen, right? By definition, they're devoid of allergens because they don't have any proteins, they don't have any peptides. So they're the most hypoallergenic. In fact, actually, hypoallergenic is a misnomer. They're devoid of allergens. So this started this whole process, right? So, but then people figured out, oh, they have other sort of benefits. They have benefits in short bowel syndrome, for example, which is when the small bowel is not working because it gets readily absorbed. They help with chronic pancreatitis. They help with inflammatory bowel disease, such as Crohn's disease, ulcerative colitis. But there was one big problem. Amino acids, most of them are very sulfury, so these taste like sewage water. So essentially, it's impossible to drink, especially the original formula. But the good news is that now, with the advent of flavor engineering, now there are palatable ones that after 50 years, so now the code is cracked essentially. Now you can have it, you can drink it. Because we used to give them only with NG tubes. Now they're drinkable. So flavor engineering has improved so much. I don't know how many of you guys have seen the movie by Charlie Chaplin, when the Gold Rush. There is a scene that they're eating their boot. So it's interesting that the joke among food engineers is that that's now reality. I can put a blindfold on you and I can make you eat your shoe because I can make anything taste like anything that I want, which is interesting. But in this scenario now we have palatable elemental diets, right? So we just ran this trial, the first trial with this, about with 30 subjects with SIBO and also intestinal methanogen overgrowth. And we did 1 week of screening, 2 weeks of elemental diet, and 2 weeks of follow-up. And we collected a lot of data, including daily questionnaire and also stool imaging. Okay, so in GI we do a lot of odd things. One of them is that now people have to take pictures of their poop so we can see exactly what's going on with each bowel movement, so we can assess it on a daily basis. So we have objective data, right? Because relying on, let's face it, people and patients saying that how did your poop look like, that's a little bit unreliable, including me being in these trials. So, so this will give us a little bit more objective data. This shows that, first of all, out of all 30 subjects, all 30 of them were able to finish 14 days of exclusive elemental diet, which was a great advancement because in the previous trials we could only crack into 50, maximum 60% compliance rate. And they preferred the taste, which was good. And as you can see, the eradication rate that we achieved was about 73%, which was actually relatively, at least comparatively just by numbers, is more than the antibiotics that we get in these patients, which is not surprising. And this is actually the data that we have based on the app, the completeness of the bowel movement. Because one thing that patients with bacterial overgrowth get that they can't evacuate. They continuously have sensation of incomplete evacuation. They always feel full, right? So that completeness actually increased from 38% to 69% within actually 2 weeks, which is actually pretty impressive. And then the number of bowel movements as determined by the stool image actually continue to improve even after they restarted the elemental light. So this kind of like shows you how the field is advancing. And we just actually finished the microbiome analysis, and essentially what it does is that it gives you a gut reset. Your native bacteria in your gut are not dependent on the food you eat. They're dependent on the regular sloughing of your bowel. Your small bowel sloughs every 5 days. The lining of your small bowel and your large bowel every 5 days renews. So those cells that die, they just fall off into the lumen, right? So your regular bacteria, your normal flora survives on that. It's just the invasive bacteria that are dependent on the food that you eat. So when you have a food that does not reach the rest of the bowel, you get almost like a factory reset. And we know this data actually based on the hibernating bears, right? After 6 months, when they wake up, there is a study that was done in Scandinavia. I don't know who was that intern that went and collected poop from a bear that was waking up. But it's not that after 6 months of hibernation, your gut bacteria all dies. No, actually it resets because it's not dependent on the food they eat, right? So this also jives with all the data that we have with benefits of fasting. But again, in a lot of patients with autoimmune disorders, with a lot of patients which are already malnourished, the fasting can't be implemented as a concept. All right. We also do meal spacing that is helpful to give bowel rest in between meals because that helps the housekeeping waves to happen. And that's how housekeeping waves show up actually on the manometry testing that we have right here. And also we do have medications to help accentuate those housekeeping waves, right? For example, we have good old erythromycin. We have azithromycin. Pulmonologists love azithromycin. We use it too. So that is very helpful in helping the gut move. Also, we have prucalopride, which is another sort of medication that is out there, approved by FDA, more expensive than the others, but it also works with the movement of the gut. So just to give you an idea, so it has a lot of symptoms that can happen with small intestinal bacterial growth. We diagnose it mostly with breath testing, but if needed, a small bowel aspiration, and induction of remission and maintenance of remission is very important. But this is something that is not going to completely go away, so we need to maintain it. So that's one important thing to understand in terms of management of it. And that's actually is very important because in a lot of times we do this irrespective of the pathology in patients with scleroderma in terms of dietary habits, but more importantly, the pro-motility drugs that we help to get the bowels push. But hopefully with the help of the medications that Dr. Boyne discussed, hopefully we can even restore the motility of the small bowel, hopefully one day that we can even cure these. And these are our team, and happy to answer questions after that. Thank you so much.